Hi, this is Dr. David Lubarsky, CEO of UC Davis Health and the Vice Chancellor for Human Health Sciences. Nothing about science right now is more important than the science of wearing a mask. We're lucky that we have one of the world's experts, the head of our infectious disease division, Dr. Stuart Cohen, who knows more about this than just about anybody. And he's here to share with you what we know now about the truth of mask wearing. And not to kind of ruin the ending, they work. And so what we're hoping is that anybody who actually watches this and listens to Stuart will become an ambassador for doing the right thing, because wearing a mask is not about red, blue, Democratic, Republican rights or impositions. It's about the public health and it's about your health. So with no further ado, Dr. Stuart Cohen.
Thanks, Dr. Lubarsky. Very nice introduction, and I echo your comments. And so I was asked to talk a bit about the role of masking with COVID-19. And I'm going to just start out by showing this picture that was identified from the 1918 influenza pandemic. So this is obviously a baseball game where batter, catcher, and umpire are wearing masks. And if you look in the background, the people in the stands are also all wearing masks. So 100 years ago, I guess, was a simpler time, and people didn't seem to argue with what made good common sense. I'm going to just describe briefly how the virus that causes COVID-19, which is called SARS-CoV-2, is transmitted, and then identify a little bit of a difference between what we call aerosol transmission and true airborne transmission. I'm going to define the role of masks in preventing transmission, and then a little bit about the Cal-OSHA policy on use of N95 level of protection, and then our mask policy, or at least a modification of our mask policy as the final topic. So first off, let's just focus on the pictures on the right. So the virus comes from somebody's mouth. And so whether you're wearing a mask or whether you are just speaking or whether you are breathing or whether you're singing or screaming, there will be a certain amount of virus that's released. And while it may generally be transmitted about 6 feet, it might go a little bit further if people are screaming or singing. The second point is that the speed of the air and how much air comes through the rooms will dilute how much virus is there. So if the air is very stagnant, if it's just sitting in the room, the virus is not going to get diluted. If the air exchanges are fast, like they are, for example, in an operating room, then it will be diluted significantly. And that also will matter as to how big of a space that you're in. So if it's a poorly ventilated small room, that's a much higher risk than a well-ventilated big room. And the lowest risk is being outside, because one of the things that does kill microorganisms is ultraviolet, which that sun shown here provides the ultraviolet. How much time you spend in a space with somebody also determines how much virus you're exposed to, and then how close you are to people, so the crowdedness. And then personal protection works to decrease your risk. So the risk is reduced by being further away, by the infected person wearing a mask and the non-infected person wearing a mask, by cleaning your hands and disinfecting surfaces. And then, as I've always said, hands have to go to your face in order to transmit. So it's a less efficient way of transmitting than via a breathing route.
So, can you just stay on that slide for 1 second?
Sure.
A lot of people have talked about airplanes and are concerned about travel, but in point of fact, right, there's really good air circulation in there and very few reported cases on airplanes. Is that not true?
That's actually correct. And I think, you know, particularly if they require masking on airplanes with the added air exchanges, and I think all the airplanes have also enhanced their filtration systems, I think the risk is comparatively low, surely lower than people think it is. And I'm unaware of any major transmissions on airplanes, as you've noted.
Right, and all of these things, as you've mentioned, they're all joint probabilities. So the more of these things that you do, which is avoid crowds, don't spend a lot of time in a place without good ventilation, be in a bigger room than a smaller room, and all those things added up together. So you're basically constantly juggling this, right? At least, are you doing that in your mind?
Yeah, right. It's just as shown in the middle, right? You're really rolling the dice, right? And you just want them to be loaded dice rather than not, right? And loaded in the positive manner.
Yeah, no, so it is really within our control if we're really paying attention to all of these things, right? This is the crux of the matter. If we're paying attention to all of these things, and we also put on a mask, it means that, well, when you put on that personal protection gear, then the volume of shared airspace becomes less important. Still important, but it's a way of in each of these places, whether it's being crowded or with time, or with the way that the virus might circulate in one of these rooms. If you're wearing a mask, it's affecting almost everything, right?
That's totally correct.
Okay, just wanted to make clear. So it's not one or the other, it's one and the other. Okay, thank you.
Yes, sir. So this is just another way of looking at this. So this is a paper that was just recently published, and it looks at particle counts. So this doesn't look specifically at virus, but it looks at particles. And you can see the colored lines. So the blue line is people that are about a foot away. The red line is 3 feet away, and the green line is 6 feet away. And then the number 1 through 7 goes from no face covering to an N95. And in between, you have a face shield only, a cloth mask, face shield plus a cloth mask, surgical mask, and face shield plus surgical mask. And what you can see is that with no face covering, the amount of particles that are transmitted either 1 foot, 3 feet, or 6 feet is higher than just about anything. And that if you wear a face shield only, it really isn't that much different than not wearing anything at all. And when you wear a cloth mask, that clearly decreases the amount of transmission. 1 foot, 3 feet, and a little bit less 6 feet. And then a surgical mask is a little bit better than that. And then adding the face shield to the surgical mask is better than that still. And then an N95. So when we're working in a healthcare setting and we're wearing a surgical mask and a face shield in contact with patients, or if we're going to be in contact with other personnel for prolonged periods of time, that surely decreases your risk and almost reaches the same level of protection as if you were wearing a fitted respirator, an N95 respirator.
And that sort of explains the results we've had at UC Davis, right, Stu? I mean, we've practiced usually droplet precautions, which was a face shield and a surgical mask, and we had very low transmission rates at all, either internally among employees or from patients to employees, and that is consistent with this data.
Correct. So let me point out a couple of other things. So I think that, first off, many of the studies that look at aerosolization of virus are not looking at patients. They're using machines to generate aerosols, which you can do with influenza just as easily as you can do with SARS-CoV-2. And the second point is that being able to detect RNA, which is what our COVID test identifies, doesn't necessarily mean that you've got viable virus there. So in this particular study, which was published a long time ago, it seems, July, right, so early in the pandemic, 38.7% of the samples had RNA in there, but they were unable to culture any virus out of this. And several areas were sampled where they did aerosol generating procedures, AGPs, and there was still no difference in the amount of virus. So you can find RNA, which is probably in viral capsules, but are not infectious. But that doesn't necessarily correlate with viable virus. And so that, I think, led to a lot of misconceptions as to how far virus could be spread and how much transmission can be can happen based on that. And again, I think when you use a aerosol generating machine compared to a human, you're talking also about a different level of even RNA being present.
Yeah, you know, those are some really important issues, because you always hear on the news, right, the sensationalism, which is, oh, they detected all this virus lingering in the air for 12 hours or whatever. But a lot of it is actually virus that is not viable. That is, it won't live, and it won't live to infect you. Some of it may, as you've mentioned, but the point is that's not the predominant way that this actually spreads, probably. And there's very little understanding of how that, you know, what that really means. And so you really have to read the papers to know whether or not those sensationalist stories are actually correct.
I think one of the things that I saw one of my colleagues present at a national meeting that really sends this point home is back from 1970, so 50 years ago, there was an outbreak of smallpox in a hospital in Germany. And the patient, who is in green down here on the first floor, transmitted virus to other patients on the first floor, but also to patients on the second and third floor over the course of several days, as you can sort of see there. So that's real airborne transmission, right? That went throughout the hospital. I think there have been circumstances with tuberculosis where in a school, somebody had TB and the kids in the room next door converted their TB tests, and the kids coming into the classroom after the in the next period, many also did convert their skin tests as well. So that's the difference between a true aerosol organism and or a true airborne organism. Excuse me, I'm starting to confuse the terms too. A true airborne organism versus a droplet organism that can be aerosolized in certain medical situations. So it's a very different thing. What we do for tuberculosis is not necessary for COVID-19.
All right, so it's a little, would you say it's still mostly droplets, but some smaller particles in some instances may linger in the air, but it isn't as if you breathe in a room and then someone else walks in 2 hours later and gets sick?
That is correct. That's not been demonstrated. And again, it really isn't something that has been identified, right? I think one of the things, I didn't make a slide of it, but one of the things that people sometimes bring up is there was an outbreak in a restaurant in China that involved a couple of different families. But if you look at the way that that restaurant was laid out, there were, I think, 5 or 6 big tables, and the 2 tables of people who got infected were in the direct line of the ventilation system, so that the virus got pushed along to this group of people. And everybody on the other side of the restaurant didn't get infected. And so if this was really an airborne infection, everybody would have got it within the facility, not just the people that were in the direct line of fire, so to speak.
Great points, Stu. And again, that study was sensationalized as showing that restaurants were very dangerous places and that it was airborne. And in point of fact, probably not, although restaurants are still somewhat dangerous places, especially if we're not well distanced and there's not any outdoor ventilation.
Right, I think, right, restaurant ventilation probably doesn't meet the standards of what we would expect in a medical facility. I just point this out without going through details. This was also taken from a presentation at our national meeting, but it's our data. Derek Bays is one of our fellows. This is a study that many of us contributed to. And it just points out 2 cases of patients that we had who were late to the to be identified as having COVID-19. So there were a lot of healthcare workers that were exposed. And you can see in the first case, there were 147 exposed healthcare workers. 15 were defined as high risk and 73 as medium risk, and there were no transmissions. And then there were 145 exposed in the second patient, and there were 5 transmissions, all of which were present during an intubation, which was an emergency intubation, so it was not a controlled circumstance. And one wore only a surgical mask, and everybody else didn't have eye protection or a mask that were exposed. So I think that this is strong evidence from our own facility that this is not that easy to get unless you're in the right particular circumstance. Using our standards from back in March of 2020, so more than 6 months ago.
Yeah, there are a number of patient to healthcare worker transmissions here in the organization. Seems to be very, very low as long as PPE is being worn.
And this I think points to some of the issues that recently have been re-described by CDC. So what this demonstrates is that if the symptomatic person or if the infected person, whether they're symptomatic or asymptomatic, is not wearing a mask, there are going to be a lot of droplets, there are going to be a few small particles, and then the healthy person, if he or she is wearing a mask, then that decreases their risk of transmission. But it's more effectively decreased if both the infected and uninfected person are wearing a mask. So I think initially the messaging was that you wore a mask to prevent transmission to anybody else. But it's a two-way street. The mask not only prevents transmission to somebody else if you happen to be infected, but it protects you if you're not. And so that is why I believe that the state of California has also changed their rules today to basically require that if you are in a circumstance where you are indoors with other people and you're not behind a closed door like I am right now, or like Dr. Lubarsky is, that you need to be wearing a mask. So, it goes both ways. It cuts down what gets spewed out, and then it further cuts down what you breathe in.
Yeah, I mean, and even if you're 6 feet apart indoors with very little ventilation, like an office, you should be wearing, both people having the conversation should be wearing a mask. And even though someone looks healthy, they may not be healthy. So again, it's just, no one likes wearing a mask, and hopefully in months, we'll be done with this. 6 months, maybe, if everything goes according to plan with vaccines and distribution. But for the next 6 months, we've got to double our efforts in getting everybody to wear masks. They work.
I think if you wear them enough, you don't even realize you're wearing them after a while, to be honest. I've tried to eat through masks and a face shield before. So I think after a while, it just becomes part of your body. I do want to point out that when infection control, and this comes from CDC, and it comes from NIOSH, the National Institute on Occupational Safety and Health, that there's a hierarchy for how we prevent transmission. And PPE, the mask, is sort of the lowest level, but it's the one that we have the most control over. So we have tried to decrease the hazards by our visitor policy, by increasing the number of virtual visits, by people working from home. We've tried to replace some of the hazards by using clean surfaces. We've tried some engineering control, which is isolation, and our rooming algorithm, and how we manage aerosol generating procedures. And we try to change the way people work by changing workflows and by doing all the screening that we do at the doors of people coming in, and then PPE. So we have dealt with this whole hierarchy, with the whole inverted pyramid of infection control strategies to decrease the risk. So, so there are a lot of other things in the background, but the PPE is what we can control, and that's what we need to be vigilant about.
Right. It's pretty straightforward. I mean, I think, you know, the elimination is you know, will get us where we want to be, but until then, masks are really easy to find and put on. All right.
So I will mention two quick things that no one's really going to want to look through, but I will just say that the way Cal OSHA looks at this is they say anything that's a novel pathogen should be managed as an airborne infection until proven otherwise. And so I brought this up before. I'm not sure when COVID-19 isn't novel anymore, right? I think most of us are pretty sick of it. So we're not really looking at it as being novel, but their rules sort of are a little bit different than what I've been presenting so far, just so that people realize that one of the policy changes that we've made has been to meet this Cal OSHA guidance, not necessarily because the data support it. And so we have reworked our isolation protocols for patients that have documented COVID-19, or for people who are being screened who are symptomatic. So not necessarily surgical pre-ops or just hospitalized patients that we do routine screening on. This is for people that we either know have COVID-19 or we really think do have it. And we use what we call enhanced droplet and contact precautions, which just means that you wear an N95 instead of a regular surgical mask in the room. Everything else exactly the same as it has been before. And again, this is less based on science and more based on administrative policies to meet what Cal OSHA's guidelines suggest.
I think that's really important, Stu, because you know, again, many of our employees and staff, you know, get conflicting information about why is Cal OSHA saying something different than some of the health systems were saying, and the reason is because we don't believe that this is truly a novel virus anymore. It's been with us, sadly, since January in the United States. It has occupied our minds and our efforts for the last 11 months running. And we have a really good idea how it spreads and how to prevent it from spreading. And so our definition is based, frankly, on the science of its spread. And Cal OSHA's is based on its definition of the virus is still novel. And that's just, you know, we disagree, but they're the regulatory agency, and so we're going to follow what they're saying. But it doesn't change the science, and it doesn't change the risk. And there's nothing wrong with wearing an N95. It's a little more uncomfortable to breathe through, however.
So that was my last actual data slide, but the one thing I wanted to actually comment on is one of the things that I've seen presented at other meetings, and I've also seen in publication in relationship to this masking. And that is that there's never been a randomized double-blinded trial of parachutes if you're jumping out of an airplane. But there's not very many people who don't have a suicide wish that aren't going to use a parachute if they're jumping out of an airplane. And I believe that this is the same idea here. We're never going to have a totally perfect blinded study that demonstrates absolutely that this is the best thing ever. But we have a lot of data that support it, and it's just common sense. And I think that we really need to be smart about this. Things are flaring in Sacramento County now. We've already moved up to the purple tier again, and the number of patients are increasing in the hospital again. I think with the holidays coming, with Thanksgiving and then the Christmas and New Year's holidays, I think we're looking at potentially a lot of transmission, and we just have to be smart about it and be careful, because as good as California has done compared to some of the other states, we're not New Zealand. And I think that's an important point.
Yeah, anytime you bring a lot of people in the room together, there's a high likelihood that one person may be an asymptomatic carrier. And you know, there are statistics to describe this, but the smaller the gathering, the less likely any one gathering will lead to multiple infections of loved ones. So this Thanksgiving and this Christmas and this winter holiday season, keeping gatherings small is really going to be critically important. And the other thing is, you know, I just want to comment on the difference between a belief and a consistent theory. So there's some people who believe that masks don't work and they have no proof. And they say, well, you don't have proof that masks work. And like scientists, we agree with them, but we say there's a but. Every single piece of data that exists is consistent with our belief that masks work. That is, societies that traditionally wear masks have lower incidences. We can measure the decrease in virus particles surrounding a recipient when there is a mask. We can measure the decrease of virus particles that get through the mask to the person who's likely to be infected. We can look at the fact that in some areas where there were mask mandates versus other cities not in the same state, those with mask mandates had lower incidences of infection. So while there may not be a double-blind study, as Dr. Cohen said, every single piece of evidence that we have, almost without exception, as far as I know, says that masks do work, and since we know it's transmitted by the larger number of particles that you're exposed to, and we know that masks decrease the number of particles you are exposed to, if everybody wore a mask, we would get control of this pandemic much more quickly and much more completely than we're doing now. Stu, any last words from you?
No, I think you summarized it as well, if not better than I can do.
Only you know 10 times what I know. So it's better to have the expert saying that than anyone else. And I just hope that people will listen out there. And you, if you're here working with us in this organization, I hope you believe it and that we will serve as an ambassador to tell your friends and your family, even those who are doubters, about what you've heard today. And maybe, again, one by one, if we convert people to doing the right thing, we will all be better off. All right, well, I think we're gonna close with that. Stu, thank you so much for your amazing work, your amazing leadership on this issue, and for keeping us grounded in the science. It is truly appreciated.
Thank you.